an insight into the newer strategies that we have at our hand to deal with this difficult situation called psoriasis. I'll be presenting a new molecule called Epimolars in psoriasis. Dr. Vinay Singh speaks about JAK inhibitors and psoriatic arthritis by Dr. D.S. Bhakuni. Then we'll have a panel discussion of all the faculty, and Dr. Vinay Singh is going to, moderate that session. So I have the pleasure of presenting the first session, which is on Epimolars. I'm just sharing my screen. Jitin, can you call Dr. Vinay and tell him to join in, please?
I am already there, sir.
Oh, Vinay, make an opening comment, please. I'm sorry.
Sir, thank you so much. You have already done the job. So, dear friends, thanks to Dr. Ganju for opening this meeting. And I from Iadvl Delhi State Branch welcome all of you on this day, which is being celebrated across the globe as World Psoriasis Day, 29th of October. And today we are going to learn newer frontiers, newer modalities of treatment, and also we'll be touching upon older modalities of treatment of psoriasis and also the most commonly associated comorbidity with psoriasis, that is psoriatic arthritis. We have two eminent rheumatologists, Dr. Indrajit Agrawal and Dr. Darshan Singh Bakuni, sir, to enlighten us with their views about psoriatic arthritis and also the modalities of treatment of psoriasis. We have our past Iadvl Delhi State Branch President and past National Iadvl Vice President and a very eminent speaker, a very versatile human being, Dr. Anil Ganju, who will be presenting the first session on psoriasis management, newer treatment modalities with a drug which is a wonder drug in many of the cases. So I request Dr. Ganju to begin today's session by his talk. Over to you, sir.
Thank you very much, Dr. Vinay, for those kind words. And it's really nice to have psoriasis as a multi-specialty CME in this condition, which is a multi-specialty problem. We have realized in the recent past that there are a number of other problems associated more than the skin involvement. So, friends, I'm going to present this new molecule to all of you, which I find quite enterprising. It's Epimolars. There has been a lot of apprehension in the recent past about its side effects, but I find it very, very useful in my practice if I use it, very judiciously. I'll tell you how. So, friends, this is a very novel molecule, an inhibitor of an intracellular enzyme called phosphodiesterase 4. Phosphodiesterase 4 is a very important enzyme in the inflammatory cells, because it is basically an inducer of the inflammatory cascade through production of inflammatory cytokines and through downregulation of anti-inflammatory cytokines. So phosphodiesterase is an important step to begin the inflammatory cascade, not only in psoriasis, but in several other autoinflammatory disorders. This is the first targeted synthetic DMARD, was first approved in USA by the FDA in 2014 September for use in moderate to severe plaque psoriasis. It is the first small molecule and has a very unique mechanism of action, as I've already told you. The Indian authorities have approved its use in 2014, again for use in psoriasis. Now, if we go to the mechanism of action, before we go there, I have this slide which very briefly describes a very, very complex pathogenesis of psoriasis. The psoriasis immunopathogenesis, as we have tried to understand it in the recent past, has been found to be very, very complex. But this slide gives it very briefly and in a very simple manner. So psoriasis happens in people who are genetically predisposed to get this disease, and in combination with this genetic predisposition and environmental factors that lead to trauma in the skin, which could be UV light, which could be mechanical trauma, which could be chemical trauma. All these environmental factors act as triggers. They induce certain stress and oxidative stress within the keratinocytes. The keratinocytes liberate various cytokines and induce CD8, CD4 T cells to induce this inflammatory pathway. There is an increased Th cytokine production, the gamma interferon, the TNF-alpha, the IL-2, IL-1, IL-6. All these induce the dendritic cells to produce IL-23. The IL-23 induces the Th17 T cells to produce IL-17 and IL-22. These are the final cytokines which induce dermal inflammation and keratinocyte replication, respectively. There's also an increased expression of the CXCL8 ligand, which produces chemokines that are responsible for attracting neutrophils into the epidermis, leading to production of pustules and microabscesses known as microabscesses of Monro. And there is increased expression of the vascular growth factors, which induces angiogenesis in the superficial dermis. There is increased expression of the STAT3, which induces keratinocyte proliferation. So this is in a nutshell how the psoriatic pathogenesis happens. Now, coming to the enzyme phosphodiesterase 4, this is an important enzyme which is present in almost all the inflammatory cells, and its activity reduces the cyclic AMP levels within the inflammatory cells. There is an increased level of the adenosine monophosphate, and this adenosine monophosphate induces production of various inflammatory cytokines and decreases the production of anti-inflammatory cytokines. And apremilast as a drug interferes with the activity of the phosphodiesterase 4, it inhibits it. So as a result, there is a decreased conversion of cyclic AMP to AMP. There are increased levels of cyclic AMP within these inflammatory cells. The increased levels of cyclic AMP induce the protein kinase A enzyme, which has a positive effect on the cyclic AMP response element binding protein, or the CREB, that leads to increased production of anti-inflammatory cytokines, and it has a negative effect on the nuclear factor kappa light chain enhancer, which leads to decrease in the inflammatory cytokines. So there are two opposite effects: decrease in inflammatory and increase in anti-inflammatory cytokines. So in psoriasis, apremilast, by blocking the phosphodiesterase 4, decreases the chemotaxis of neutrophils, and also decreases this inflammatory cascade. So all this put together, all the pathogenic mechanisms involved in the psoriasis plaque are inhibited, and thus the inflammation is taken care of. So as I've already told you, it has been approved by US FDA in September 2014 for use in moderate to severe plaque psoriasis by the Indian authorities the same year, October. And in addition to psoriasis, there are a number of off-label uses where apremilast has been found to be very, very promising. So there are anecdotal and large studies available where autoinflammatory disorders like or immune-mediated inflammatory disorders like atopic dermatitis, alopecia areata, like Behçet's, like lichen planus, HS, palmoplantar pustulosis, pyoderma gangrenosum, sappho, vitiligo, sarcoidosis. All these situations have found apremilast to be of quite a good help. The good thing about apremilast is that it can be administered orally, which makes it quite an easy drug to administer. The bioavailability is high, about 73% after an administered dose. The highest or peak plasma levels are reached in 2.5 hours. It is bound to protein to the tune of about 68%. Metabolized in liver by cytochrome P450. So we have to be careful about drugs that are metabolized through this system or drugs that inhibit this system. They can lead to changes in the levels of apremilast. Half-life is 6 to 9 hours, and it is eliminated primarily through urine. Now, there are a number of studies that have been done in psoriasis: ESTEEM-1, ESTEEM-2, LIBRATE, which have compared apremilast with placebo, or apremilast with etanercept, or then switching over from etanercept to apremilast. In all these studies, apremilast 30 milligrams twice a day has been seen to be much more efficacious than placebo, almost equally efficacious to etanercept. And patients who were not doing well with etanercept or had shown partial response to etanercept, when they were put on apremilast, they showed better response. This is a graph where it is seen that the improvement happens as early as 2 weeks of initiation of 30 milligrams twice a day. And this effect is reached to the maximum in about 16 weeks, about 70% reduction in the PASI score. And thereafter, the effect is maintained as long as the treatment is given for at least 52 weeks, as far as this study is concerned. Biologically or systemically naive patients who have not been given, other drugs have seen maximal improvement in skin, scalp, and nail psoriasis, improvement in pruritus and quality of life. And this study was done for a period of about 104 weeks, comparing the placebo, apremilast, and etanercept. Etanercept and apremilast were found to be somewhat similar in efficacy. The mean change from baseline compared to placebo in patients with apremilast was found in up to 48% improvement from baseline, as against 56 of etanercept. When at 16 weeks, the placebo arm was given apremilast, there was an improvement to the tune of about 60% at 52 weeks. So apremilast definitely worked in patients who had been put on placebo and had not done well earlier. In patients who with etanercept had given about 56% change, about 56% improvement in those patients when they were changed to apremilast at week 16. At week 52, we found that about 72% improvement was seen in those patients. So apremilast can be given not only in systemically naive patients, but in patients who have been given biologics already, who have reached a plateau, or who are not responding to biologics, like when there is biologic fatigue. Then when we change over to apremilast, the patients show a better effect. This is a study. It also showed that NAPSI, or the nail psoriasis severity index, improved considerably with apremilast. When apremilast was started initially, within 16 weeks, there was a considerable improvement. At 32 weeks, further improvement. And patients of placebo who had not done well earlier, when changed over to apremilast, they started improving with this. Special areas like palmoplantar psoriasis, nail psoriasis, scalp psoriasis, and patients with comorbidities are specially seen to be doing well with apremilast 30 milligrams twice a day. One example of palmar psoriasis improving within 16 weeks of treatment with apremilast. Plantar psoriasis with pustulosis improving in just 4 weeks of apremilast. Nail psoriasis within 24 weeks. Erythrodermic psoriasis in an elderly with hypertension showing improvement in just 10 days. Pustular psoriasis showing improvement in 2 to 3 weeks. This is particularly interesting because in this patient, they had seen that this patient had hepatitis, had cirrhosis, had metastatic hepatocellular carcinoma. So multiple comorbidities, but still the patient showed improvement as far as psoriasis was concerned. Also, the pruritus and skin discomfort associated with psoriasis has been seen to improve considerably as early as 2 weeks after the initiation of therapy, and this effect is sustained for up to 52 weeks. Apremilast is a safe drug, and it does not affect your immune system to a large extent. It does not affect the hepatic, renal, functions to a large extent. So it can be easily combined with other antipsoriatics. The comparison of methotrexate monotherapy with apremilast monotherapy and combination of methotrexate and apremilast, as seen here, showed that the combination had a synergistic effect, up to 84% achieving PASI 75 in 12 weeks with the combination, as against 35% with methotrexate monotherapy or 33% with apremilast monotherapy. So the combination worked better. And the good thing is that it doesn't add to the side effects of methotrexate because it's a relatively safe drug. It can be combined with several other antipsoriatic therapies. Combination with narrowband UVB therapy particularly has been found to be very promising, about 89% showing a PASI 75 at 12 weeks. Methotrexate, apremilast, I've already told you, it can be combined with cyclosporine, acetretin, TNF-alpha blockers, ustekinumab, and it has been seen that in patients who have been on TNF-alpha blockers and have shown less response later on because of biologic fatigue or other features or contraindications developing, then changing them over to apremilast improves the outcome in patients of psoriasis. So where do we use it? We use it as a monotherapy in systemically and biologically naive patients when the patients who are coming to us for the first time. We can switch from etanercept to apremilast, as has been shown in these studies, where these patients did better after they had been treated with etanercept. And it is particularly useful in difficult to treat areas like the palmoplantar, nail, and scalp psoriasis. It can be combined with several other agents. Of particular interest is this potential weight loss effect of apremilast that has been seen. How it causes it is not known, but it definitely leads to some weight loss. And this is interesting, particularly in patients who are obese, and because of obesity have a greater risk of going into a psoriatic march and developing a full-blown metabolic syndrome. So these patients who are obese would definitely and particularly benefit out of this medication. Not only would their psoriasis be taken care of, but because they would lose some weight, the psoriatic march progression would also be less. Now, coming to side effects, apremilast does not have major side effects. It has minor side effects, but these minor side effects sometimes can be very, very disturbing, and patients may not adhere to treatment because of that. But we have ways and means of dealing with these. So diarrhea, nausea, headache, nasopharyngitis, and upper respiratory infections are the common side effects that we see. So how do we manage these? If you come across diarrhea happening because of apremilast, you hydrate the patient well, tell the patients to take small frequent meals, avoid dairy, caffeine products, avoid artificial sweeteners, and give them symptomatic relief as long as they have this symptom with loperamide 2 to 4 milligrams 4 times a day, or drugs like that. Take care of nausea with diphenhydrinate. Take care of headache with proper sleep and paracetamol, nasopharyngitis with hydration and avoiding irritants, etc., etc. Why I am saying this is because these side effects are usually short-lived. If you are able to, first avoid these side effects by proper titration of the dose, I'll come to that. And if they happen, if you are able to provide patients symptomatic relief and proper counseling and handhold them through these side effects, these patients are usually able to come out of the side effects, and then they benefit out of the good effects of the drug. This is the dosage schedule that has been, proposed for administration of apremilast. You start with a 10 milligram on day 1, you give 10 BD on day 2, you give 10 and 20 day 3, 20 day 4, 20 day 5, and thereafter you give the full dose of 30 milligrams twice a day. But in practice, I have found this dosage titration not very useful, and most of my patients used to come back with diarrhea, sometimes very severe, to the tune that they would need admission and intravenous administration of fluids, etc. So what I did was that I titrated the dose further. Now I start with 10 milligrams and give it for about 10 days, go to 20, give it for 10 days, go to 30, give it for 10 days, and then if required, give it twice a day. This I have seen is associated with lesser side effects, higher therapy adherence, and lower treatment dropout. So because you have less side effects, the patients are happy, they adhere to treatment and do not drop out of treatment. The adverse events are usually short-lived and do not last for long. And most of the patients will have them within the first 2 weeks. And by about week 4, if you are able to control their side effects properly, and if you are able to counsel them, handhold them properly, you will walk through these side effects easily. And by week 4, the patient will be free of side effects. Another good thing about apremilast is that you don't need to be worried about hepatic, renal impairment. In hepatic impairment, you don't need to adjust the dose. In renal impairment, unless it's very severe, where you need partial adjustment of the dose. Otherwise, in mild to moderate renal impairment, you don't need to adjust the dose. You're not bothered in geriatric age group. You can give them the full dose. Just be careful about pregnancy, about nursing mothers, and pediatric age group. So patient counseling is extremely important if you have to give this drug. So these patients have to know that there are side effects that can happen, and those side effects are short-lived, will resolve as they keep on taking the medicine, and they can be taken care of with proper intervention and management and symptomatic treatment. Therefore, friends, the take home, the oral agent apremilast is a novel drug with a very unique mode of action. It inhibits the phosphodiesterase 4 enzyme in the inflammatory cells, increases the cyclic AMP levels in these cells, which increases the anti-inflammatory cytokines and decreases the pro-inflammatory cytokines like TNF-alpha, gamma interferon, IL-12, 17, 23. The efficacy is seen as early as 2 weeks and is maintained for a long time, as seen in various studies. It is usually very effective in difficult to treat areas like nails, scalp, palmoplantar areas, maintains a good clinical response for a long period, particularly in patients who have been given biological therapy and develop biologic fatigue, as happens in TNF-alpha blockers. It is beneficial in systemic and biologically naive patients. You don't need to do many laboratory investigations to initiate the therapy or to monitor the patient. Safety has been proven for at least 3 years. It has a synergistic action with other antipsoriatic agents like methotrexate, like UVB, cyclosporine, acetatin, etc., etc. Has an effect on the weight. It leads to decrease in the weight, so is quite useful in patients who are obese and are likely to develop metabolic syndrome. Effective in systemically naive patients who have not been given any treatment earlier. Safety, I have told you. Does not have any immunosuppressive effect. That's very important. You see, it doesn't cause immunosuppression, unlike other agents like biologics and other DMARDs. So rather, by targeting the central inflammatory signaling pathways, it proves to have an added advantage compared to the conventional drug. So very good toxicity profile. Only the minor initial side effects are a bothersome issue, which can be taken care of the way I have told you, by proper titration and by intervention medically and systemically. So it becomes an attractive option for patients of psoriasis who require long-term treatment in combination with other DMARDs or alone. Thank you very much, friends. We will be having further questions during the panel discussion. Over to you, Dr. Vinay. I am stopping sharing my screen.
Thank you, Dr. Ganju, sir. A wonderful cover about a new drug, apremilast, which is very useful in many of the patients, as you have shown in your slides in your presentation. As apremilast has been taken care of, so I'll not be covering this particular molecule in my talk. I'll share my screen. Here we go. I hope it is visible now. Hello? Is it visible? Yeah. Okay, so my topic today is psoriasis, as we are discussing on World Psoriasis Day. And what are the unmet needs so far? We have been, in past, we have been treating with methotrexate, we have been treating with light-based therapies, which has improvised. We have been treating with biologics, we have been treating with, in past few years, apremilast is there. So many drugs are there, but still there are various unmet needs in treatment and management of psoriasis patient and their families. So I'll just cover few points about psoriasis since it is World Psoriasis Day. So I take this privilege of, we all know that it is an immune-mediated disease where etiology is not yet known. It could be autoimmune, maybe it is only keratinocyte which produces certain cytokines, maybe some insect bite, maybe some viral infection, bacterial, we do not know. It is not yet defined. And it can be provoked by external and internal triggers, which includes minor trauma as in kibnerization, sunburn, infections, etc., etc. Skin, some systemic drugs, and of course, stress and alcohol does increase psoriasis lesions in a patient, but they do not lead to psoriasis development. It manifests, we know this thing, and there is obviously a visible disfiguration. And most important thing is that psoriasis is a lifelong disease in a patient, and because it involves a cytokine cascade, there is immunity involved, immune mediation is involved. So patient during the course of their life, they develop numerous comorbidities, which can be very disturbing for the patient and the family in physical and psychological burden, and it does impair the quality of life of the patient, which is very, very important to be targeted while we are treating and managing the patient. So there are various unmet needs while we are treating the patient. This slide shows the prevalence. It's a textbook slide, so I don't have to speak much, but it is more common in males as compared to females, and it can occur in all ages. We all know this thing. But good point is that most of the patients, to the tune of close to 80% of the patients, they suffer mild psoriasis, which can be controlled by topical therapies alone. This is a textbook slide. Textbook I have picked up from Lancet, but it does not say that how many patients are not satisfied. We know that what are the sites of predilection. Commonest is the skin, and various other small areas can be involved, which could lead to more stressful life for the patient. Nails, of course, it's a very big disfigurement, and most of the nail psoriasis patients, they develop psoriatic arthritis later on to the tune of 40%. And very rare is mucosal involvement, but inverse psoriasis is very easily seen, as we all dermatologists, including Dr. Sikri, myself, Dr. Ganju sir, and Dr. Gaurav, would be seeing so many inverse psoriasis patients. So etiology, we do not know, but there is one gene which source 1 to 9, 9 loci are there, which lead to a patient susceptibility. And there is 50% of genetic susceptibility to a disease. And this loci is implicated in other autoimmune and inflammatory diseases. So that is why we say that the psoriasis is combination of autoimmune and inflammatory, both the diseases. And that is the reason why we are, once we start targeting one particular cytokine, other cytokines start playing their role. And that is why we see fatigue with various drugs. Like biologics, we see some fatigue after a long-term treatment with the biologic. So, and there are immunological factors. We do not know what exactly, but innate and acquired immunity both are altered, and environmental factors, as I have just now discussed. But it was found some 20 to 25 years back that primary cytokine like TNF-alpha and interferon-alpha, they were released in all the patients, and because of the environmental triggers, and hence development of biologics was there. So, and this we know that it manifests as plaque and childhood psoriasis, inverse, pustular, and erythrodermic psoriasis. And as Dr. Ganju sir has shown, the immunological cascade, which is there to whatever we understand now. We are still finding new ways, newer cytokines, newer interleukins. But these are all targets of psoriasis, including the TNF-alpha, including interleukin 12, IL-23, and so, and if we can target any of these or all of these together, then our job is probably done. But we do not know how to target all of these together, because we target only one, and after some time, because of the other from other side, other angiogenesis is there, or there is recirculation of T cells, or the keratinocyte K6 factor is there, whatever is there, the cytokines are, the body starts releasing cytokines again, and leads to the proliferation of keratinocytes, again leading to plaques. And the second episode or the third episode after a continuous treatment is more in that particular point of the patient, and leads to comorbidities again. But we discuss so many things about psoriasis, that we have methotrexate, we have Epimolars, we have biologics, we have narrowband phototherapy, etc. But are the patients satisfied? At least not in India. The clinical goals of for us are different, and the patient's expectation is different. There is a delay because familial experience of the disease, if they have heard about it. In India, what happens is they see a full page ad from a homeopath and they rush to them, and then after some time they come back to the original physician or dermatologist that my disease has increased. Cost is a prohibiting factor because it's a lifelong disease. If the patient is suffering from diabetes, patients and the society accepts it because it is not seen outside. Hypertension, it is not seen outside. They keep on taking, they may not visit their physician again and again, but they keep on taking the same treatment, same prescription, because they do not know what is going on inside. But with psoriasis, what happens is they stop the treatment, they reduce down the medication, or they change the therapy, and the disease exacerbates, and it further adds to the cost. There are many patients, all of us are having, who have previous failed therapies experience, and probably it was not properly diagnosed, etc., etc. And this all leads to sense of hopelessness about our therapy, about a medicine which we are giving, be it anything, be it biologic, be it non-biologic DMARDs or whatever. And also, patients know that it is neither curable, they read on Google, nor life-threatening. So they are not very enthusiastic about taking treatment about psoriasis. We have to tell them that it can involve so many comorbid conditions. So there is a very big treatment gap analysis, which there are effective treatments available, but we know that the patients are undertreated. And this finding from National Psoriasis Foundation from 2003 to 2011 shows that the severity of psoriasis, mild, moderate, and severe, almost half of the patients who were being treated with mild psoriasis, they were not receiving any treatment because of some reason. In India, patients have to, most of the countries, patients, they get therapy from insurance agency or from government, but also there is a delay in active modality of treatment. So this is an important slide where almost 10% of the patients with severe psoriasis were not receiving any treatment during their lifetime in 2011. So this is an important thing. And many of the patients were undertreated. 30% of the patients with moderate psoriasis were undertreated. 20% with severe psoriasis were receiving only topical medication because that was either available OTC, or that was the only one which was prescribed by a family physician, and they were not having access to a dermatologist, or they did not have money. There were so many reasons involved in it. So this is important, that 50% were dissatisfied with their treatment for psoriasis, and hence they kept on discontinuing and again clinging to the disease, to the physician. So in 2018, survey was done where in 31 countries where more than 8,300 patients were surveyed, including in India. 57% of moderate to severe patients of psoriasis, the survey did not achieve clear or almost clear skin on current therapy, be it whatever, be it topical, be it oral, be it biologic, be it light-based therapy. They were not having clear or almost clear skin. 56% those who had not met this goal believed it would be impossible to do so. Add on Google information. And 73% had not initiated their current treatment until more than 1 year after psoriasis diagnosis, because of the reason that in India it is very easy to order a medicine on phone, but outside India it is not very easy to get the medicines until you have a valid prescription. And they had to wait for more than 5 years also. So the majority of the psoriasis patients worldwide are undertreated, including in India, because of either economics involved, market access, various health policies of various different countries, different governments, lack of established treatment goal from the physician, primary care physician, or the dermatologist also. Because of some reasons, like in India's various government physicians, government dermatologists, they cannot initiate a biologic therapy if required in a patient. I'm not saying that every patient needs biologics. So there is always a misalignment in the treatment expectation and clinical goals. Most of the patients are unaware that there is a possibility of attaining 100% clear skin, whether in short term or long term. They should be continuing the treatment, whatever is there, or they can achieve a substantial improvement or elimination of the troublesome symptoms. And if they continue the treatment, then they can reduce the chances of getting comorbid conditions during their whole of the life course of the treatment. And misalignment was reported to the tune of 70%, almost 70% in patient-physician perspective. So major reasons are patients, they expressed a higher goal. Of course, any patient would want a quick therapy than physicians, and the dermatologists who recognize patient expectations in order to reach those goals were not able to prescribe adequate medication because of the reason whether the patient was having some comorbid condition, etc., etc. So this is present psoriasis treatment scenario. Increasing toxicity, if you take, then we move from ladder of topical to phototherapy to systemic therapy, which includes retinoids, methotrexate, cyclosporin, biologics, Epimolars, and other small molecules which are there in the market, and with increasing effectiveness of the treatment. So if we teach the patient that this disease, although this is going to stay there for lifelong, but you have to take it as any other comorbid condition which you are maybe suffering, or your family members are suffering, like diabetes or blood pressure, which are very well accepted in society, then there is a chance that patient may continue the treatment. So far we have been treating with various oral medication, then came biologics in 2004, started with etanercept. In 2019, risankizumab is there, which is in pre-approval stage. We have certain biologics which are available in India, and all of us have used it. They are good therapies. There is a higher patient satisfaction with biologics compared to conventional systemic and topical therapy, because the patients can continue with a better and quicker response. But and biologics, they have a meaningful effect on systemic comorbidities. They can prevent, if started well in time, metabolic syndrome, cardiovascular disease, NASH, and multiple sclerosis also. It can be delayed or prevented. So the patients who have failed topical therapy, who have can go for phototherapy, biologic agent. This is the norm which we all follow in our patients. Biologics, we know what are these. They target very specific part of the immune system, and they are given by injections, IV, or by subcutaneous way. So, and we can get a very quick reduction in baseline PASI, 5-point or greater improvement in DLQI very quickly with biologics, and adequate response of the treatment. Since 2004, since etanercept was introduced, it was to achieve PASI 50. Now, in past 5 years or past decade, PASI 75 was the target. Now PASI 100 or clear skin is the target, which can be achieved. We are able to achieve, but still the gap remains. The gap is that biologics, these are monoclonal antibodies, we all know, or they are recombinant proteins, and they target only one cytokine or the receptor binding site. We have been successful in treating some of the patients, but after some time, the biologic fatigue is there, or we know that targeting a single cytokine does not completely abrogate the pathology or pathogenesis of further development of plaques of the disease. So in past 2 decades, our knowledge of intercellular pathway downstream of cytokine, as Dr. Ganju has shown in his slide, and I have also shown in one of the slides, we have been able to identify receptor-associated kinases, which is a novel way to simultaneously inhibit multiple cytokines. And these are orally available molecules. They can be passively transported through cellular membrane, and they block the intercellular activity of their targets. These are Janus kinase signal transduction and activator of transcription, or JAK-STAT, commonly known, signaling pathway, and it is implicated in the pathogenesis of various inflammatory and autoimmune diseases, including psoriasis and psoriatic arthritis. I'm sure our rheumatologist colleagues who are there today with us, they will be able to tell us, because they have been using it in various rheumatology indications, including RA and including psoriatic arthritis, during our panel discussion. So several cytokines, they play a central role in pathogenesis of inflammatory and autoimmune diseases, and if we can inhibit those pathways, then with JAK and STAT pathways, then we are able to reduce down the inflammatory cascade. Mutations in JAK and STAT genes, they cause a number of immunodeficiency syndromes, and polymorphisms in these genes are associated with autoimmune diseases. In past 15 years, the understanding of JAK-STAT pathway and JAK-STAT gene has given us a new avenue of treatment of these autoimmune and inflammatory diseases. So JAK inhibitors are effective in treatment of rheumatoid arthritis, which is the very important disease for which they were tried and they have been shown very good results. And other investigations for many immune-mediated diseases, including psoriasis, SLE, IBDs, and rare autoinflammatory diseases with type 1 interferon signature gene is alteration is seen. Now, that was the story of first generation JAK inhibitors, which inhibited pan-JAK. Now, second generation JAK inhibitors are more selective, and they are studied for the therapeutic efficacy and their side effect profile. And we also know that intercellular pathways downstream of cytokine receptors have been studied, and now our understanding says that inhibition of intercellular enzymes such as receptor associated kinase represents a novel way with lesser side effects, and we can simultaneously inhibit multiple cytokines. This is a structure. It is named against a Roman god. It is a family of tyrosine kinase, and JH1 and JH2, they denote the kinase and pseudokinase domains. I'm not going into much of the detail. JH1 is an active catalytic phosphotransferase domain and the target of JAK-inhibs developed so far, which compete with ATP at the catalytic site. Like Epimolars competes with cyclic AMP, here it competes with ATP at the catalytic site. And there are 4 JAKs, JAK1, JAK2, JAK3, and tyrosine kinase 2, and 7 stats are there, which are under study, which are being studied, and they are being medicines are being developed. This is an important slide. Upon binding of a type 1 or 2 cytokines to its cognate receptor, the JAKs are activated and phosphorylate the STAT transcription factors critical for the activation of cytokine-specific genetic programs. This STAT transcription factor transmits type 1 or type 2 cytokine signals downstream of the JAKs. STAT proteins, they contain an amino terminal, a coiled coil, a DNA binding domain, a linker, and hence it directly binds to the DNA of the inflammatory cell. So if we are able to, there is a cytokine, we are able to inhibit the JAK and STAT pathways, then we are able to prevent the release of cytokines. STATs can be phosphorylated by kinases other than JAKs, including FLT3R and pyroid kinase, and this is still under process of studies. So action we have just seen there. How does it act? So in nucleus activated STAT dimers, it incorporates into the DNA and hence releases the cytokines, and it further becomes a cascade within the cell. It keeps on releasing the cytokine in the question for that particular disease. I'll not take much of the time, but it is important. So these are the potential uses. As I said, that we have been able to understand about the JAK and STAT pathways, that they are involved in various autoimmune and inflammatory diseases. So we can take help of JAK and STAT pathways. This is one of the newer modality of treatment. Apart from biologics, they inhibit only single cytokines or single interleukins. Here we can inhibit multiple at one go. And currently in India, only immediate release JAK inhibitors are available, but outside India, delayed release are available, which have better compliance by the patient. So future prospects are that clinical trials are going on. Diseases which are characterized by serum elevation of JAK-dependent cytokines could respond well to all JAK inhibitors, which include various diseases, including psoriasis, SLE, myositis, scleroderma, primary Sjogren's syndrome, etc. So there is still, and these are the future prospects where we can inhibit release of various interleukins and cytokines through various Th1, Th2, Th17, and Treg pathways of all these important cytokines, which are important for all these diseases, including atopic dermatitis, alopecia areata. There are anecdotal reports of wonderful result with JAK-inhib, which is available in India, about not only about rheumatoid arthritis but psoriasis, rheumatoid arthritis. There are so many truckloads of evidence available throughout the globe. But with psoriasis, it is available also in various journals. But in SLE, alopecia, vitiligo, contact dermatitis, atopic dermatitis, there are certain anecdotal reports going on. Thank you so much. So this is my presentation about the unmet need. We still are trying to find a good solution for psoriasis and psoriatic arthritis. Now, I would request Dr. D.S. Bakuni sir to present his experience in psoriatic arthritis, current concepts of management of psoriatic arthritis.
Am I audible first? Let me ask that.
Yes, sir.
Wonderful, sir. Wonderful. I'm really happy that you have overcome the problem.
Yes.
Thank you. Thank you very much. I think my slides are also being seen clearly.
Yes, sir.
Okay. Thank you, all the speakers. And Dr. Vinay, you made my job simple by discussing JAK inhibitors. And thanks to Dr. Anil Ganju for discussing it, tablet apremilast also. So I'll be very brief in my topic, which is current concepts of management of psoriatic arthritis. So why this is important? Why should we discuss this disease? Firstly, today is psoriasis day, number one. Number two, psoriasis is a chronic, progressive, and relentless disease. So much so that people dread to have this disease, or rather any disease for that matter. But since it is seen from a distance, people really dread to have this kind of disorders. And top of it, 30 to 40% of the patient of psoriasis, they develop psoriatic arthritis. That's why we come into the picture. And out of these 30 to 40% patient of psoriatic arthritis, 20% of them, they develop permanent joint deformities and loss of function. Imagine a housewife cannot work her work, cannot perform her day-to-day activities for the family. Imagine a breadwinner is disabled. Usually this psoriatic arthritis appear after 5 to 12 years of skin lesions. However, at times we have seen that skin lesions and arthritis, they come together. But the problem comes where? When there is no skin lesion and still we suspect that the patient may be having psoriatic arthritis, when the patient comes to us with dactylitis and DIP joint involvements. Of course, at that time, if the other joints are involved, we are confused with whether the patient is having just plain rheumatoid arthritis or not. Why I have mentioned these two features, dactylitis and DIP joints, because they help us to diagnose that it is not a case of rheumatoid arthritis, because in rheumatoid arthritis, DIP joints are never ever involved for all practical purposes. And if the patient comes with dactylitis, even if there are no skin lesions, we still suspect that patient may be having psoriasis, if not today, then tomorrow. Of course, after excluding the other causes of dactylitis, like excluding sickle cell disease, tuberculosis, sarcoidosis, and bacterial infections. And one more thing I want to tell you, even if in rheumatology the diagnosis is wrong or the label of diagnosis is wrong, but the treatment is almost same all over the, for almost all the conditions of autoimmune disorders, may it be rheumatoid arthritis or SLE or other diseases. So we are safe, even if you give wrong label or diagnosis to the patient, but the patient does not suffer because of the treatment part. So is the remission possible in psoriatic arthritis? Yes, it is possible like in rheumatoid arthritis, because in one of the studies which was published in 2020, it showed that 60% patient of the psoriatic arthritis, they went into remission after 1 year of biologics. So remission is possible. If tomorrow or in future, further drugs may be coming, which again will make it possible to have it happen. However, a word of caution, if the medication is stopped, as Dr. Vinay said, the patient, they go to homeopathy or Ayurvedic treatment or something like that, they relapse within a month. So we should not stop the drug. We should, educate the patient that the relapses are very common if you stop the drugs. That is a word of caution here. Now, what should be the strategy to overcome psoriatic arthritis in an effective way? The strategy which we follow here is treat to target strategy. And this strategy was supported by the International Treat to Target Task Force, ULAR, and GRAPPA. Why this approach? Why this treat to target approach? Because it was shown in this study that there are significant benefits in disease outcome, physical function, and it enhances the quality of life. And other newer drugs are, are possible to further make the patients in remission because of the newer insights into the pathogenesis of psoriatic arthritis. Because more the cytokines, more the receptors we are finding in the pathogenesis of psoriatic arthritis, more the molecules we are getting for the treatment. There is one study known as tight control of psoriatic arthritis known as TICOPA trial. This is the most famous trial for management of the psoriatic arthritis, and it was a randomized, controlled, parallel group, open label, multicentral clinical trial of 206 patients with early psoriatic arthritis. It was conducted over the period of 48 weeks for each patient, and it was compared with the standard care versus tight control, as I told you. The study was conducted between 2008 to 2013, and it was published in 2015. So much so that principal investigator of this paper, he also followed them for long-term, and he published the long-term follow-up results in 2020. What he found that both the arms were taking biologics equally, 52 and 54% in standard care group as well as the tight control group. And use of methotrexate decreased in both, most likely because methotrexate did not function and the biologics, they took over this thing. And it also revealed that a tight control group did not result in greater biological use in long term. That did not mean that to have a tight control, you have to use biologics. No, this studies of, this trial in the long-term follow-up proved that. What this trial did, they diagnosed this patient early, and all the patients were, DMARDS naive patients, and they planned to eliminate the joint inflammation and also to have the prevention of the structural damage and thus enhancing the quality of life. So these were the top, headings they started their trial. And they used 7 components of minimal disease activity comprising of tender joint less than 1, swollen joint less than 1, PASI score less than 1, patient visual analog score less than 15, patient global disease activity less than 20, and health assessment questionnaire was less than 0.5. And tender enthesitis points were less than 1. So these, when this target achieved, that was the strategy to reach this target in this trial. However, in clinical practice, later on, what we saw, and this is the Western figure, that only 56% of the healthcare personnel, they use this treat to target in a strategy. Why? Because there are disadvantages. While the trial was itself going, because there was increased adverse side effects and there was increased visits to the hospital, not very pertinent to our country, because in Western country you have to pay through your nose if you are not insured, and of course there are increased expenses. What they found was the most important thing, that the patient education and the doctor's capability to educate the patient played a big role to convince the patient to have this tight control and to have those drugs to achieve those minimal disease activity goals. So the doctor's role is also there to impress upon the patient and their attendant to continue the treatment. In India, how many of us we are using this strategy? The figure is not known. If you see the cost effectiveness of the treatment of psoriatic arthritis in USA, without biologicals, it is around $5,000 per year. With biologics, around $20,000 per year. In UK, if you compare with biologics, it is around 20,000 British pound. Whereas in India, although no data is there, but we can guess by our day-to-day clinical practice that around $500 without biologics and around $2,000 to $3,000 per year if the patient is using biologics. And if the patient is using just tofacitinib or JAK inhibitors, the expenses are further lower down. This helps us to achieve the goal of treat to target strategy. Now the biomarkers. Non-specific biomarkers, everyone knows that ESR and C-reactive protein. However, the specific biomarkers for the research purposes are Th17, C8, CD8 positive C cells, which are increased in synovial fluid in active psoriatic arthritis. The potential biomarkers, again, in the for the research purposes, are metallic MMP3, DICOF, DKK1, macrophage colony stimulating factor, and osteoprotegerin, OPG. This is for the theoretical part I wanted to cover. Now, what is the treatment strategy? We can divide psoriasis for the treatment as mild and moderate to severe. What is mild psoriatic arthritis? When the joints involved are less than 4, there is no radiological evidence of any damage, and there is a minimal functional impairment. And moderate to severe, persistent inflammation with a poor prognostic markers as, beside that the joints are more than 4 and there are radiological damage and functional impairment. There is increased number of inflamed joints, raised ESR and CRP, failure of previous medications, presence of joint damage, radiologically and clinically both, and loss of function and poor quality of life. So these features, they bring down the patient to the moderate to severe category if we start treating these patients. So what are the recommendations? The ACR recommendation and National Psoriatic Foundation recommendations are really around of 2018 or so. So what latest we have is EULAR recommendations, which we are following. And it says that for musculoskeletal symptoms like pain and swelling, one can use NSAIDs and local steroids injection for enthesitis, as well as for any local lesion and as well for arthritis. If the one particular joint is to be injected, we go all out. And systemic steroids, it says that avoid systemic steroids except the low doses to avoid the skin flares. But in clinical practice, what we have seen and what I am doing, that the patient wants a relief. So what I do, I prescribe 15 milligram of prednisolone once in a day for 15 days. After that, 10 milligram of prednisolone only for 10 days. After that, I bring back the patient to 5 milligram per day, maybe 2-3 weeks more, till the time methotrexate or other drugs, they start acting. So these minuscule, the minimal doses, it says, although the definition wise minimal dose or low doses, less than 7.5 milligram. But 15 milligram once in a day for 15 days and further down to 10 milligram once in a day for 10 days does not do any harm. I have not seen any skin flare in my patients. Now, further recommendation says patients with polyarthritis. If the patient comes with more than 5 or more than 5 joints, start conventional synthetic DMARDs, and the most preferred is methotrexate. If methotrexate one cannot give to any patient for some reason, we can also start patient on leflunomide and sometimes sulfasalazine. But favorite drug is methotrexate. And patient with mono or oligoarthritis who are poor prognostic markers, same methotrexate. We can start. In nutshell, if I say that, if I will not be wrong, that whenever a patient comes to us with psoriatic arthritis, even if it is monoarthritis or polyarthritis or oligoarthritis, we put the patient on methotrexate because we want to hit the disease hard early in the beginning, so that the damage is restricted in the future. So any patient with peripheral arthritis with inadequate response within 3 months to these synthetic DMARDs, we can start biologic DMARDs. And TNF inhibitors like etanercept, infliximab, adalimumab, they are preferred over other biologics. So they are time-tested drugs, and we can use them. However, if the patient of psoriatic arthritis has not improved and he has relevant skin involvement, what we prefer are IL-17 inhibitors like secukinumab or IL-12 or 23 inhibitors like ustekinumab. And any patient with peripheral arthritis with inadequate response to synthetic DMARDs and at least one biological DMARDs. The recommendation of EULAR, which is again almost 2 years old, it says JAK inhibitor. But ladies and gentlemen, I can tell you in practice, we start JAK inhibitors if the patient fails on methotrexate or leflunomide because of one simple reason, rather two simple reasons. It is cheaper. It is much cheaper. All of us, we know that it costs around 1,200 to 1,500 rupees per month for the patient to bear the expenses. And whereas biological DMARDs, they cost around 17 to 18,000 rupees per month to the patient. And we give option to the patient, and basically this is oral drug. So we do not wait and we do not follow this recommendation of EULAR here. If the patient have mild disease with inadequate response to synthetic DMARDs and in whom neither a biologic DMARD nor a JAK inhibitor is appropriate, as Dr. Anil Ganju said, PDO4 apremilast is the preferred drug, which has fewer side effects, very easy to monitor, and also the weight loss also. So the obese patient, they prefer this drug. However, if the disease is moderate to severe, apremilast, it doesn't work. Please don't use it there. Now, patient with enthesitis and inadequate response to NSAIDs and local steroids, there are studies which say that we can again start the patient on methotrexate, and the studies are coming now. However, the recommendation of EULAR, it says biologic DMARDs. One can use if the patient of enthesitis because at times they are frustrated because there is no joint pain, no joint swelling, but still there is a pain around the joints because of enthesitis. And of course, as we know, if the patient with predominantly axial disease or spondyloarthropathy, biologic DMARDs, especially the TNF inhibitors, are preferred because they are cheaper also, and again they are time-tested drugs. However, if the same spondyloarthropathy or patient with axial disease with relevant skin disease, IL-17 inhibitor like secukinumab is preferred, and that is also the recommendation. So patient failing to respond to biologic DMARDs, say patient, we have put the patient on adalimumab or etanercept, we can switch over to another biologic DMARDs or targeted synthetic DMARD. We can switch the patient to tofacitinib or any other drug. So switching is allowed. It all depends upon the administration route or the patient's affordability. Whichever the patient can afford, and if you can be motivated or convinced, we can switch over to that kind of DMARDs. And the patient, as I told you, the 60% of in one of the studies, the 60% of the patient of psoriatic arthritis on biologics, they achieved remission around 60% cases. So that does not mean that we should stop the treatment immediately. As I told you, because the relapses occur within few months or within a month or so. So there should be cautious tapering. What I do in practice, for example, say adalimumab, the patient has to take every 15 days. After 6 months or 9 months, I increase the duration from 15 days to 20 days. After that, I make it 25 days. Then once in a month. So once in a month is good for the patient as he can afford it nicely. But I have not been able to stop the medication of any patient till now, which went into remission. So the take-home message for my simple lecture is today that start methotrexate or any synthetic DMARD like leflunomide at the earliest. May it be mild, may it be moderate, may it be severe psoriatic arthritis. Please don't stick to NSAIDs only, which many of our other colleagues outside, those who are not neither dermatologists nor rheumatologists, they are doing it. A local steroid injection for enthesitis or arthritis, very effective. If it is not effective, think for the use of biologics, biologic DMARDs. Avoid systemic steroids if required, only low dose for a short period. Again, I'll again repeat for the benefit of the audience here that start with 15 milligram once in a day for 15 days, 10 milligram once in a day for 10 days, then bring down to 5 milligram for another 2-3 weeks, depending upon the response. When the methotrexate or the other DMARDs they start acting, stop them. And the most, I'll say revolutionized treatment has come JAK inhibitors. Since when they started, I think they costed 36,000 rupees per month. 3 years back, they were 24,000 rupees per month. Around 2 years back, the cost was around 18,000 rupees per month. And then today, the drug companies are ready to give for 1,200 rupees per day. And they are effective also. The effect starts coming within 2 weeks. So instead of biologics, we can think of using JAK inhibitors. Watch for adverse effects of medications by constantly monitoring them. Of course, Epimolars is a good drug which does not require that kind of constant monitoring. And for axial disease, use biologic DMARDs if without any skin flare or much skin lesions. If with skin lesions, please think of IL-17 inhibitors like secukinumab. And if you want to start tapering in a patient who has gone to remission, please taper cautiously. Ladies and gentlemen, thanks for listening and viewing this thing. Thank you, Dr. Vinay. I finished.
Thank you, sir. Thanks for a very good overview about current concepts in management of psoriatic arthritis. And now we will be starting with the panel discussion with the eminent panelists, which include two rheumatologists, Dr. D.S. Bakuni sir and Dr. Indrajit Agrawal sir, and very eminent dermatologist with a very keen interest in autoimmune diseases, Dr. Rajiv Sikri, Dr. Ganju sir, who has just now briefed us about usage of Epimolars, a wonder drug, and a very dynamic dermatologist, Dr. Gaurav Nakra, who is current secretary of our state branch, Iadvl Delhi state branch. So I will start with Dr. Gaurav Nakra. We all have spoken so far, but I will start with Dr. Gaurav, Dr. Indrajit sir, and Dr. Rajiv sir. Dr. Gaurav,
Yes,
how
sir.
about how is good evening, Dr. Gaurav? Welcome to the meeting. And how about your experience of dealing with pediatric psoriasis patients?
Sir, as I'm only practicing at my own clinics, so I'm not attached to any hospital. So I have experience in treating pediatric psoriasis patients who are mild, like who fall in the category of mild psoriasis. Generally, severe psoriasis patients, they are generally getting themselves treated at hospitals or big corporates or government setups. But psoriasis being such a common condition, we do occasionally get patients of pediatric psoriasis which are extensive, but it's not very much. Like, we don't get a lot of patients.
Yeah. Why I asked is that psoriasis, we know that it involves all of the age groups, and there are two major age groups involved as per the genetics goes. One is pediatric psoriasis, and one is the psoriasis which is adult, which manifests in adult. And as Dr. Bakuni sir has already briefed us that psoriasis may precede or may proceed development of arthralgia and arthritis. So, Dr. Rajiv Sikri sir, I would like your views about dealing with a patient of pediatric psoriasis. How often do you see a case of pediatric psoriasis, and how you deal with that? Rajiv sir, you're not audible. No, sir, your voice is not there.
It is okay now?
Yeah, it is okay now, sir.
Yes. Yeah. Give me the question again because there was a net break.
Yeah, sir. I was asking about, we are discussing about psoriasis on World Psoriasis Day. And to start with, we know that psoriasis involves all the age groups. So in your experience, your clinical experience, how often do you see a pediatric psoriasis patient, and how you deal with such kind of patient? Then I'll be coming to...
Yeah, see, very less often, of course, first. And there are two, my choices are oral retinoids, and which is my first choice in age small. Like infantile psoriasis, maybe in 6 months I get to see one patient under 1 year of age. And I find the oral retinoid is the drug of a safe and first choice. It works very well and it is safe. And then the cyclosporine, of course. I know you also love cyclosporine, and I also love cyclosporine. So then the cyclosporine, of course, in the next in the queue. And even in the pediatric age groups, like a child with 2 years or 3 years of age with a psoriasis, Dr. Agrawal, Dr. Inderjeet Agrawal, and the Dr. Vakuni, I agree with them that methotrexate remains my good choice in childhood psoriasis as well, because it's safe, of course, along with cyclosporine and retinoids.
Thank you, sir. Dr. Indrajit Agrawal, sir, continuing with pediatric psoriasis, how often you see a patient of pediatric age group with psoriasis developing psoriatic arthritis or arthralgia?
Well, first, let me thank you for organizing this meeting on the World Arthritis and Dermatology interface, because it is a joint effort that we have to always do. Well, you see, majority of the times, I try not to see pediatric patient because, I'm an adult rheumatologist, first of all. Even I have to ask to be seeing the patient, I try my best again to try to divert it to the pediatric rheumatologist. But in case, I have to see, then generally I'm more comfortable with all these drugs like psoriasis, which we use, methotrexate, cyclosporin, TNF blocker, etanercept, and definitely we don't use JAK inhibitor in childhood as such. But by and large, all these drugs, they have very significant impact. So I will not be able to quote entirely the data on how much of the psoriatic child will have psoriatic arthritis, because I'm not generally, I try to not to see this pediatric age group. Dr. Bhakuni may be able to give you some figure. Dr. Bhakuni?
Well, I just saw 2 patients when I was in RR hospital. Thereafter, when I came to the corporate hospital, they don't come to us. Usually they go to the pediatrician basically. So I've not seen any pediatric patient of psoriatic arthritis in my practice here after I, retired from the army.
Very true, sir, because in private practice, the most of such cases, they are referred or they themselves go to a pediatrician. And my point was that if they are properly diagnosed, then we can, as the EULAR says, hit hard and hit early. We can do that in pediatric age group, and we can explain it to the family that this is going to be a long-term disease. Dr. Ganju, sir, how about usage of Epimolars? It is a very safe drug and very easy to titrate, very easy to use by the patients. Also, compliance can be good if the common side effects are not there. So, in pediatric age group, have you used Epimolars?
Not really. One, because it is not recommended. As far as the recommendations go, pediatric age group, they have not, cleared its usage in the pediatric age group. One, also because it is available as a tablet, which is difficult to administer. And then the apprehension of getting these side effects, it is quite common to get these side effects like diarrhea, and sometimes they are severe. But the primary reason not using them in the pediatric age group is not being recommended for this age group. So I also harp upon, generally I give them topicals unless it's a very severe disease. I would like to add that guttate psoriasis I find happening more often in pediatric age group. So they usually respond to a course of antibiotic and a topical rather than going to some DMARD. Very rarely have I gone to DMARDs, and cyclosporin I feel is quite okay, and methotrexate now we know is quite safe in pediatric age group also. So these are the go-to drugs.
Yeah, absolutely right, sir. Pediatrics age group, they present usually with the guttate psoriasis, which is very easily manageable. But I have seen a few cases of pediatric psoriasis with psoriatic arthritis, which were very badly managed. And I'll come to that with Dr. Bakuni, sir. As you have shown and you said that you reduced down the 15 milligram of oral steroid along with methotrexate, But what happens is that many times the patient continues taking that steroid, and when the steroid is withdrawn either by the pediatrician or maybe by the patient himself or herself, both in pediatric and adult age group, then the psoriasis lesions, they flare up. Second thing, methotrexate, we all know that it takes around 6 weeks to start showing its effect. So, is it always recommended to club the two together and then go ahead for the
Yeah.
sake of clinical practice? I'm saying.
To be very, very honest with you, if I don't start steroid, the patient will run away. For what reason? Because they are suffering from pain, stiffness, other things. And I tell them the guarantee is, today I'm giving you 15 milligram, by tomorrow morning you will be much better. That creates a faith in the doctor, and I'm not harming the patient by giving this 15 milligram. And as I'm telling you, I've not seen a single patient whose skin, lesions flare. Of course, I'm talking about adult patients, because it's a very minuscule doses. After 10 days, after 25 days, it becomes 5 milligram. And for another 2-3 weeks, till the time 4 to 6 weeks, after that, the patient, they come back to us for monitoring, and they adhere to the whatever advice I give.
Of course, sir, because the patient is in severe pain, and they understand that the relief of the pain is given by the doctor, and they stick to your words. But in dermatology practice, as my colleague dermatologist would agree, that if we give them steroid for only skin disease, and then they may continue and then withdraw, and it becomes bad. Yes, sir, you wanted to make a point?
Yeah, I just want to add one more sentence, that I also assure them that I'm not starting any painkillers. I don't prescribe any NSAIDs. That also, adds to the doctor's, impression that the doctor is good. I'm just telling you whatever you can say, the secret or whatever, it is not a secret. But I just tell them, see, there is no painkiller. I'm just giving this steroid for such a short duration, and the patient is happy and doctor is also happy.
Okay, thank you, sir. Dr. Rajeev, sir, I would like to ask you about sequential management, sequential therapy in a psoriasis patient who has been taking treatment but has been showing waxing and waning effect of the current medication. So how do you plan to do sequential therapy, and what is exactly is the sequential therapy for the benefit of our viewers? Please elaborate on that.
So methotrexate, oral retinoids, and now JAK inhibitor. So I will put them in a sequential therapy. And,
okay.
So I'm happy that with the JAK inhibitors, it's like an oral biologic, it works very well. So JAK inhibitor, retinoid, and methotrexate. So you go around between the two. So I know the rheumatologists, they don't have any cumulative dose for methotrexate, but we dermatologists, we have that 4 gram upper limitations. So that's why I opt for rotational between these 3 molecules.
Yeah, rotation and sequential therapy holds good for psoriasis patients, various psoriasis patients. As you very rightly said, that rheumatologist colleagues of ours, they start with 25 milligrams and they do not consider any cumulative dose to be, prohibiting us from continuing further methotrexate. Probably it is the genetic component which involves psoriasis, where liver is damaged more as compared to rheumatoid arthritis. Dr. Agrawal, sir, your views about this discrepancy in two views?
Well, first of all, let me be a little honest with you that, I try to avoid steroid if I can. Because, after all, in a young girl, if she has psoriasis and somebody has given a small dose of steroid, that can be extremely helpful. You come across some patient who have had vascular necrosis. So, but then in Indian perspective, I can understand why Dr. Bakuni is trying to give steroid to try to get rid of the pain. Secondly, the problem comes that you rightly said that there is going to be a problem, starting the dose of methotrexate. Well, I also felt that in Indian context, the patient do not generally tolerate very high dose of methotrexate to start with 25 milligram. So I think probably let's put it this way, that look, we try to use a higher dose, definitely from the dermatology colleagues, and that I used to say in England as well. But nevertheless, I try to not to give very high dose to start with, because you never know that almost 50% of the patient will report some nausea, vomiting, GI discomfort, and they will then lose faith on you or lose faith on the treatment. And we all know for India and for the rest of the world also, methotrexate is probably one of the most important anchor drug, we have to say. So yes, I try to use lower dose, but then, there are many rheumatologists who like to use higher dose.
Sir, continuing with you, sir, have you come across any patients who are crossover between rheumatoid arthritis and psoriatic arthritis?
Yes, we see some patients, we have got maybe about, say, a dozen patients, so on, but not normally. And it is like, you can see psoriasis, psoriatic arthritis, sarcoidosis. Recently you have some patient who have got, say, lupus with psoriasis. Then, all these autoimmune diseases can be there. But, I think probably overall, it is a bit rare. And at some point, as you have all mentioned, that seronegative arthritis, for example, today's last patient, I had labeled her as a seronegative arthritis. And today she came after so many months and she showed me her hands and feet, and she had the palmoplantar psoriasis. So I think probably all these combinations will be there. So we should not be thinking that it is rare, but consequently, the treatment approach, however, is going to be the same. So if you treat psoriasis, psoriatic arthritis, rheumatoid arthritis, because the combination of the drug therapy are fairly the similar one.
Thank you, sir. Dr. Ganju, sir, what would be your ideal way of treatment, quick treatment for erythrodermic pustular psoriasis patient?
Okay, before I go to that, I had raised my hand a long time ago.
Oh, I did not see, sir. Sorry.
This is a very, very useful opportunity for us to get, to learn from our rheumatology colleagues. The two things that were discussed over these recent, time between in the panel. One was steroids. So I wanted to tell my colleagues in rheumatology that for us, steroids is an absolute no.
No.
So if any of our teachers comes to know that we have given steroids, so this is one autoinflammatory condition where steroid is an absolute contraindication for us, number one.
Right.
Number two, I would want to learn and gain confidence on usage of methotrexate, which we are generally very wary of. We start with a 5 milligram dose, get a count CBC and LFT done after 1 week, because we are fearful of the idiosyncratic reaction that can happen and lead to pancytopenia or suppression. But seeing the rheumatology colleagues' prescriptions, they go straight away to 15 milligrams, never bother to do it at 1 week. They do it, of course, maybe after a month or so. So I want to gain confidence from you guys about use of methotrexate the way you do. One, I want, should we now forget about giving a low dose and then monitoring immediately after 1 week, which probably you people do not do? And also the upper limit, as Dr. Rajiv Sekri was mentioning, earlier it used to be 2 grams for us. Now it is 4 grams, but is it the same for you, or are we unnecessarily apprehensive about it? First, let us get this from our learned colleagues.
Yes, Dr. Bakuni, sir. Sir, you are not audible, sir.
Actually, we start with 15 milligram, not 25 milligram. 15 milligram orally, max to max 20 milligram orally. And after that, if the patient requires more drug, we always give parenterally, means subcutaneous or intramuscular injection. And we ask for at least I ask for the TLC, WBC, as well as SGPT and serum creatinine before the 3rd dose of methotrexate. Why? Because the 2 doses may, if at all some reactions have to happen, usually after 2 or 3 doses. So before the patient takes the 3rd dose, I ask for CBC, ESR, SGPT, and serum creatinine. These are the investigations. So we start, again, I'm saying we start with 15 milligram, reach up till 25, parenterally, not orally. Number 2, total doses about, say, around 20 to 25 years back for us was around 4 to 6 grams. And we used, it was recommended that the patient undergo liver biopsy, but not anymore. We don't recommend anything like that. Dr. Indrajit may say something.
To be honest with you, this kind of problem used to arise when there are not many choices available to us. These days, why to give the patient, very high dose of methotrexate, make them suffer, make them unnecessary complaint of so many side effects. So 15 to 20 milligrams and that too giving subcut, is good enough because, I have a lot of choices. I remember that, when we started long back in our career in rheumatology, many drugs were not there, not many choices. So then we had no way but to keep on adding methotrexate, keep on increasing. Mind you, the patient with psoriasis and psoriatic arthritis slightly different from rheumatoid arthritis or Angst-Pond or any other autoimmune diseases because we know that the patient with psoriatic arthritis, they do have problems like, hyperuricemia, coronary artery disease, they have liver dysfunction, they are slightly sort of obese, and they also go into some kind of psychosomatic conditions as well. So I generally, try my level best not to increase methotrexate beyond 15 milligrams because we have got JAK inhibitors, because we have TNF alpha blockers. Why to just keep on increasing the dose of methotrexate unnecessarily and keeping the patient frustrated?
That's right, sir.
If I may say, what I said,
Yeah.
in patients who are not responsible, maximum patients, say around 90% patients, they require just 15 milligram. Another 5% may be requiring 20 milligram. 25, I hardly have 2 or 3 patients per week. On that too, not of psoriatic arthritis, of rheumatoid arthritis.
Fair answer. Sir, Dr. Ganju, sir, your treatment of choice in erythrodermic pustular psoriasis?
Okay. I think retinoids is a good choice for erythrodermic psoriasis and pustular psoriasis, and also cyclosporine. These are my go-to drugs for this acute emergency, because generally rest of the drugs, methotrexate particularly, takes time to act. So retinoids or cyclosporine.
And sir,
narrowband UVB therapy also can be combined.
Yes, sir. And sir, have you seen Epimolars working well in only scalp psoriasis?
I have seen it. I find this drug very, very, promising. I think there is a lot of hype about its side effects. I think if it is used properly, the way I told you in my presentation, if we build up the dose very slowly, 10 milligrams for 10 to 15 days, 20 for 10 days, 30 for 10 days, I find it very useful, and hardly any patient complains.
Great, sir. Because you mentioned that it works very well in your cases, your patients with scalp. That is why I asked you. Rajiv, sir.
Might not be 100%, but in the patients where it does well.
Right. Rajiv, sir, your experience with Epimolars vis-a-vis methotrexate?
First, I don't use Epimolars as the main drug. I always use as an add-on drug. Like with biologics, I will add on. With methotrexate, I will add on. Retinoids, I will add on. So the advantage is like methotrexate plus Epimolars, fine. So you use lesser dose of methotrexate to achieve the same therapeutic results. So I don't use it as a frontline main drug, but always add on. So this is my approach.
Dr. Gaurav Nakra, your experience with Epimolars in selected indications or maybe overall plaque type of psoriasis?
Sir, Epimolars, in my opinion, works in a variable way. Like in various patients get different kinds of response. I never use it as a drug for severe psoriasis, probably because of lack of confidence in that medicine. Initially, when we tried, it was not very helpful for severe psoriasis, like more than 40% body surface area involved. But in mild to moderate cases, because of the perceived safety of the medicine, I use it very commonly. And then mild cases are generally very well managed. So I still use it, but I've heard the presentation of Dr. Ganju sir. So I'll try it more in the scalp psoriasis patient. Till now, I had this impression that it's not very helpful. Again, patients with arthritis or severe disease, I don't find it very useful.
Okay. Dr. Agarwal, sir, earliest sign for we dermatologists to pick up a joint involvement?
Well, to be honest with you, I would rather give me 1 minute, because I always felt that enthesitis component, it is slightly difficult for the dermatologist to pick on. Because, when you see the patient, they may have normal ESR or CRP. And the patient will complain profusely of the chest wall pain, a heel pain, this pain, that pain. And then that point in time, your patient may be having fairly well-controlled skin disease. But the patient has got quite a significant enthesitis, which you will not be able to quantify if you just check on the ESR and CRP. You have some other devices like ultrasonography or MR, techniques to try to conclude that this is the case. So I think probably, look, I would definitely, from dermatologist perspective, I would say that, look, if the patient is complaining of severe aches and pain, where the significance of your skin disease is not that, but still do not think that the patient has got no enthesitis. The patient may be having some, so far as your question was concerned, joint disease. So age-old thing, like, you just see the patient joint, if it is more swollen, tender, red, and then psoriatic arthritis, slightly behaves in a different way. So distal interphalangeal joint involvement will be more one digit will be more involved than the other. Say, for example, dactylitis, one digit may be very pronouncedly affected. The next digit may be normal even. So that you see in more unilateral sort of joint pain, synovitis, that kind of picture will be there. But, age-old diagnosis of clinical medicine by looking, examining is good enough. But enthesitis, please do remember.
Yeah, thank you, sir. And as we are running out of the time, I'll have very few questions, quick questions to our rheumatology colleagues. I would like to ask why we give secukinumab as 150 milligram dose in psoriatic arthritis, vis-a-vis we are using 300 milligrams in psoriasis, plaque type of psoriasis.
Should I answer?
Yeah, please, sir.
Purely on the cost effective, because it all depends on the patient's pocket. If we can afford, we can give 300 milligrams. If the disease is milder, of course, in severe disease, we convince the patient to have 300. Otherwise, there is no particular reason that we start with 150 or 300. All depends on the patient's choice, patient's affordability. I'll just tell Dr. Anil Ganju about steroids. Sorry, I'm taking the advantage of this. 15 milligram is for 15 days. Please, we are using only for psoriatic arthritis, not for the skin lesions. What I made the statement that I have not seen any skin flare within that 25 to 30 days. That is my statement. Please don't take me wrong. There for skin lesions, I am prescribing.
That is a good observation, because we are totally scary and wary about using steroids. We never do.
Steroids.
But if you assure us, then maybe a little bit of initial inflammation we can control with.
Please use it. You will bless me.
Okay.
Dr. Gaurav, you wanted to say something?
Yes, sir. Sir, I just wanted to extend on what Dr. Ganju was asking, just to take advantage of the presence of our senior colleagues here. It was discussed that the weekly dose will not go beyond 20, as was the opinion of the rheumatologist. But we are not concerned about the weekly dose. We are concerned about the cumulative dose. So I have seen a lot of rheumatology prescriptions where people are taking methotrexate for years and years together. So are we over apprehensive about not using it beyond a specific point of time, not about the weekly dose, but the cumulative dose? And second, about the usage of methotrexate in the childbearing age or young people who are not married yet. So we are very apprehensive about that. So are those apprehensions valid?
To a certain extent, you are right, because as I said, look, psoriatic arthritis is slightly different from rheumatoid arthritis, wherein the liver toxicity is more. Secondly, I think probably also it is also a fact that, all over the dermatologists, I used to see our dermatologists in England also, where we used to work very closely, they will feel very frustrated, with a higher dose, and they will keep on adding the dose, and we will say that, look, this is this much, and we say, oh, don't worry about it, the patient will be fine. And to be honest with you, I think probably there is an apprehension. But having said that, look, we need to be very careful in the childbearing age, with the young females especially. Male, you have a lesser chance, if they father the child. But nevertheless, in the female, it is absolute contraindication. So I think probably they can be a problem if you use it in a female in the childbearing age. But nevertheless, we are not very particular about the cumulative dose. We do not calculate. I never used to calculate, and I probably will never calculate also, because we have got better drugs. I must tell you that do not just be only thinking that, okay, methotrexate is the only one choice that you have. You have so many other choices. So there's no point trying to becoming a little more, to avoid that much of dose. I think certainly I will.
Thank you, sir. And I take this advantage of thanking my panelists for giving us a view about interface between psoriasis and psoriatic arthritis, about the usage of various drugs, various modalities of treatment with Epimolars, with steroids, without steroids, with methotrexate, with JAK inhibitors, with biologics. I thank you all. And from Delhi State Branch, I hand over to our secretary, Dr. Gaurav Nakra, very dynamic secretary. He will have the concluding remarks.
Dr. Ganju wanted to say something.
Oh, sir. Please, sir.
Okay. This was an important remark about usage of methotrexate in the reproductive age group. So as we used to be apprehensive about the total cumulative dose, and now we learn from our rheumatology colleagues that you don't need to be. Also, now it is very well known that in the reproductive age group also you can play safe. For females, you just have to wait for a month for a washout period, and then the female can conceive, because there is 1 month cycle of the ova. There's nothing else that is going to happen. It's just that it interferes with the formation of the ova. And for men, you have to wait for 90 days because there is a 90-day cycle for the sperm that is involved. So for men, wait for 3 months before they father the child, and for women, wait for 1 month before they conceive.
One sentence. We asked both male and female wait for 3 months.
Okay.
I think probably that is 3 months is good enough, but I think probably traditionally it used to be 6 months, but 3 months is good enough, I think.
Vinay, all yours.
Yeah, Dr. Gaurav, please conclude the meeting. I think
lectures, and I'm sure all the audience would be greatly benefited by the combined wisdom of all the seniors who are present here. And on the behalf of Iadvl Delhi State Branch, Vinay sir, myself, and all the team, I would like to thank everyone for giving so much valuable time and enlightening us with all the knowledge on World Psoriasis Day. Thank you so much and good night.
Thank you and bye-bye. Thank you,
Bye.
Dr. G, sir. Thank you, Dr.
Thank you.
Bakuni.
Thank you,
Wonderful.
Dr. Anil. Thank you, Dr. Rajiv.
Thanks, dear.
Thank you.
Thanks,
Thank you.
Dr. Rajiv.
thank you, sir.
Thank you, Dr. Inder.
Thanks. Bye-bye.
Thank you, sir. Bye-bye. Take care.